Hi there, welcome to an exploration of the impact of acceptance and commitment therapy on functional outcomes for adult chronic pain patients with comorbid anxiety and depression. My name is Elizabeth Dion, and I am part of the graduating class of 2021 in the OSU graduate program for occupational therapy. So you see a large spread of data and text in front of you, so we'll be zooming in on various points here. This goes over the timeline of the program. What is not pictured is the initial scoping review that was completed in May of 2020 that looked at the best interventions that were underneath the occupational therapy scope of practice within the integrative medicine environment. And what came up a lot was behavioral health in order to address the functional deficits of individuals with anxiety and depression comorbid with chronic pain. So going into that realm, we did a deep dive into a systematic review of the literature, the current literature at the time for June to July of 2020, looking at the treatments for chronic pain patients with anxiety and depression. Acceptance commitment therapy was chosen due to a lot of fabulous data, and then also a focus on interprofessional treatment was found to be effective as well. So then the program was designed based on the clinic needs, which was assessed using a needs assessment of the clinic manager and a practicing osteopathic physician, Dr. Welsh. And adaptations were made to the curriculum due to the COVID-19 pandemic, and environmental modifications such as telehealth were required for implementing the program at the integrative medicine clinic. Standardized outcome measures were taken as well to assess the efficacy of this intervention. At the end, a sustainability analysis was completed with the clinic manager to address future programming at the integrative medicine clinic. This clinical guideline here, the scientific rationale for this is looking at acceptance commitment therapy on functional outcomes of adult chronic pain patients with comorbid anxiety and depression by decreasing pain interference in daily activities. And so the scientific rationale here is that there are fMRI studies that have been illustrating a bidirectional neurological relationship between chronic pain and mental health. Chronic pain patients often experience anxiety and depression, which creates an ongoing cycle and of diminished function with daily activities, poor sleep, and declining mental health. And occupational therapists are trained very well to modify daily tasks, educate patients on lifestyle changes, and implement intervention to improve mental and physical health of their patients to increase independence and function with daily tasks. And the big takeaway point here is that acceptance and commitment therapy alters the neurologic pattern of central sensitization that is common in chronic pain diagnoses by recruiting that prefrontal cortex in the processing of pain signals, whereas it would usually just hang out more in the brainstem and the limbic system. So a systematic review was completed. And looking to answer the question for adult patients with chronic pain comorbid with anxiety and depression, does ACT improve the quality of life and decrease pain interference in daily functional activities when compared to treatment as usual? 5 databases were searched, and there were multiple people that contributed to this systematic review to make sure that the inclusion and exclusion criteria were met very rigorously for this 13 full text articles, and looking at them and data extraction and quality and of evidence for the systematic review. So study designs that were included were prospective cohort studies, case control trials, or randomized control trials. Others were omitted. For inclusion in the review, studies must have used acceptance commitment therapy as an intervention in a group, individual, or combined interprofessional program. All studies included adults over the age of 18 with medically diagnosed chronic pain, and outcome measures needed to include both one outcome measure assessing pain interference in daily living activities, and it needed to also include one outcome measure on mental health quality of life. The grade system, the quality of evidence summary, comes from the Journal of Clinical Epidemiology, and it is used to look at the quality of evidence, how closely they followed protocol, and this is called the Grading of Recommendations, Assessment, Development, and Evaluations, aka GRADE. So when looking at how the 13 articles did, we grouped them into in-person and remote ACT. And we found that the in-person ACT delivery was a moderate rating of quality, and using the evidence alert traffic light grading system, it received a green rating, indicating a strong recommendation with high quality evidence and kind of the green light go ahead on the intervention. But based on the grade quality of evidence appraisal, Remote Act received a traffic light adoption rating of yellow, which indicates the use of intervention with caution. The concluding recommendation based on the grade process was for individuals over 18 with chronic pain, we do recommend the use of in-person ACT in addition to treatment as usual to improve pain interference in functional activities and mental health related quality of life. This is a strong recommendation based on high quality evidence. For translation into the clinic, my capstone experience was at the OSU Integrative Medicine Clinic. So this is a small building next to the Martha Morehouse Pavilion in Columbus, Ohio, serves many patients per year and houses a ton of wonderful integrative practitioners. And I worked particularly with one osteopathic physician, Dr. Leah Welsh, who has been working there for 4 years, working with patients with chronic pain, as well as young children with tongue ties. Additional projects completed at the site were individual OT sessions. These individual OT sessions included ACT lessons, motivational interviewing, lifestyle redesign. The program of having the OT in the OSU Integrated Medicine Clinic really focused on interprofessional patient education. So looking at what patients were having trouble with implementing at home based on professional suggestions and figuring out how to add those into their daily roles, habits, and routines. So occupational therapy interventions also were focused on ergonomics and environmental modifications for their home and professional environment. And patients were provided with experiential education on active stress management strategies, such as teaching the practice of yoga modified to individual patient needs and abilities, guided meditation instruction, breathing exercises, gentle movement, and guided imagery to facilitate regulation of their nervous system. Particularly if a provider was wanting a patient to learn to do some stress management and they were having trouble doing so on their own, it was the perfect patient to then come to OT and actually actively practice those things. So the OT identified patient barriers and difficulties with implementing their plan of care, and then customized resources for each provider and trained staff on how to use them for general OT solutions for the common patient barriers found specific to the OSU Integrated Medicine Clinic and patients and providers there. The main project was a weekly telehealth group that ended up combining multiple therapies such as USC lifestyle redesign, meditation, acceptance and commitment therapy, and interprofessional education for patients. So looking at the outcomes of how our patients did, we need a much more sensitive pain interference measure, but we found a small effect size on pain interference in the activities of daily living. There was a moderate effect size on patients' anxiety scores and a small effect size on depression anxiety scores. The practitioners at the Integrated Medicine Clinic were very generous with their time, and there was a total of 7.5 hours of the provider's personal time contributed to the program. And you can see the outcome measures used down on the side there, and modifications made for the site specifically needed to be a 7-week program rather than the 8 to 12. And to accommodate the needs of the facilities, the acceptance commitment therapy exercises were shortened and incorporated with interprofessional education. The pain interference data from one group participant was excluded from the final calculations due to the patient being admitted to the hospital and undergoing a surgical procedure. But it's interesting to note that this same patient had a 19% decrease in her anxiety scores, and she was working with OT individually and for the group sessions. So the key findings of the telehealth program included that telehealth was feasible when it was facilitated by the OT student. Family member involvement really increased patient compliance. It created a better patient-provider relationship using a facilitative, casual model of talking to people as equals rather than having an authority type of dynamic. This was an effective education model. A lot of the patients really learned a lot, and that was found through qualitative data gathered after the program completed. And there was an improved patient adherence to the plan of care and overall health literacy. To continue on at the OSU Integrated Medicine Clinic, when it comes to feasibility and sustainability, monthly telehealth groups were much more likely to be able to continue than weekly. Weekly was a lot on the facilitators, and they have a certain amount of time and a certain amount of money to be able to run things. So there are many practitioners that are interested in running it in a monthly format. And a couple of the really important points is to make sure to facilitate effective communication and education. And to do that, it's recommended that the group run with about a minimum of 4 patients and a maximum of 8 patients so that everyone's able to learn effectively and have time to speak and ask questions during the session. So adding in pain neuroscience education at the beginning is recommended to make sure that patients then are able to generalize that information across all of the lifestyle areas that are covered by future programs and future group meetings. All the presentational materials were made for free access for all of the OSU Integrated Medicine Clinic providers, and they were shown exactly where to find those in a Google Drive, very easily accessible. And there were also lots of resources for each individual provider put into that Google format as well. So they were able to find those and print them off wherever they may be. And the expected outcome of adding in these programs to the chronic pain patients at the Integrated Medicine Clinic is helping out those patient outcomes for anxiety, depression, and pain interference in daily functioning, and finding that it's going to increase patient adherence to their plan of care and provider suggestions, and hopefully see an improvement in provider collaboration, helping out both the providers and the patients themselves. The group is recommended to use a more sensitive tool for pain interference outcome and use pain neuroscience education for cognitive pain behaviors. So that is a wrap on this poster here talking about the project that I did for my doctoral capstone. If you have any questions, please feel free to email me. My OSU email will be coming down this summer after graduation. So my email is lizdtheot@gmail.com. Thank you so much.